We have community conversations.
The more people know about the service and the more people know and have a face and a name.
Everybody in their lifetime will experience some form of concerns with their own mental health.
I don't even drive this bus. It's the people in the communities that are screaming for help.
When I first went into my own personal recovery, I didn't know about programs like this.
So they make that connection, and it's really just a big networking. And when we leave, we have kind of a community that's in it together.
There's tons of positive feedback that come from individuals who are here.
There's a place. I mean, there are folks who really need that service, and there are folks that really need a psychiatric hospital in a medical setting.
Maybe one house with only 10 total beds isn't enough.
What we do is we actually go right out to the person's home and we knock on the door and we say, hi.
What do you want from us? What do you need from us?
This is a story of hope. A story about people who envision a world without stigma. It is about people who are driven to make a difference and courageous enough to do so. It is about individuals with the power to change the lives of others and the wisdom to know how valuable their contributions are. It is about navigating an ever-changing landscape and guiding others in new directions. It is the story of a place where people can be who they are and find what they have been looking for. A place where hearts and minds meet to face the most difficult of problems and rise to the toughest challenges. A place where things begin and lives are forever altered. This is the story of the Hope House.
They never point towards these awesome stories of perseverance and persistence and recovery. Those are the stories that we get to see every day, right? With the individuals we serve. You never see that in the media, ever. So it's very, very unfortunate. And again, I think that, let's have a conversation about that. Let's have a conversation about this is a real deal, but people do great things and get better every day, and it's okay to say I'm struggling with depression or I'm having suicidal thoughts. If we continue to point to the negative things of mental illness, then it's going to continue to breed the problem, and it's going to continue to have to keep people from getting the help that they need, because they look at this media and say, oh, well, this is how people who have a mental illness are portrayed, right, as these rogue gunmen. And so of course, I don't want to be associated with that, because that's not me. And so that keeps people from getting the help that they need. And so I think the media has done a huge disservice, and that they continue to kind of to breed that stigma and breed some of the problems.
I think stigma is a big problem, and we spent quite a bit of time in our CIT class trying to dispel the stigma around mental illness. I feel that it hinders the ability for people to get services, and that's why we spend so much time in our class is understanding that this is an illness. We refer it to diabetes or cancer, and how much empathy individuals have for people that have diabetes and cancer.
I think there's a huge stigma, especially in this community. You see it a lot with, there are people in the community trying to say that there isn't mental health going on here, that it's unnecessary, that the funding shouldn't be there. I think it's, a horrible stigma to be out there, because, people can't control what they're going through a lot of the time, especially with the mental health issues that they're going through, and people that have a problem with people that say that they're mentally ill, they're not just saying it. It's real. We see it every day here, and I think if people could see it in its, purest form that we get to see it on a daily basis, they would understand that, that stigma needs to be wiped out.
I think that those that suffer from a mental illness certainly experience levels of stigma that the rest of us may not experience. Historically, I've read research that has said that 9 out of 10 people suffer from some level of stigma, and actually that experience is worse than the experience of the symptoms that they suffer from having a mental health diagnosis.
20 years ago, when I was diagnosed, I had to go to treatment. My treatment was very separated. I had to go to one facility for substance abuse, and I couldn't talk about my mental health. And then I went to a mental health center and I talked about my mental health and I couldn't talk about my substance abuse. That was 21 years ago. Today it's not like that, right? Today we understand that those two things are probably going to be blended for half to 3/4 of the people we see. And that it's okay to talk about your mental health even though you might be at a treatment facility for chemical dependency, or vice versa, right? So things like co-occurring are now part of the lexicon, and so we know now that that's going to happen when people walk in. So it's changed. That's a positive change we love to see, and yet we still have a lot of stigma that keeps people from getting the help that they need. I think society as a whole is just not to a place yet where we're really willing to accept people who are maybe a little different, maybe come from a different place, maybe their emotional range is a little bit different, maybe they look and act a little different, maybe they interact a little different, they talk a little different. I don't think as a whole in society we're quite there yet.
Bozeman, Montana is home to Montana State University and more than 40,000 people. It is a city on the rise with accessible outdoor recreation and a progressive community spirit. In December of 2004, in response to the public demand for mental health services in the community, the Hope House was established as an extension of the Gallatin Mental Health Center. Realizing the unmet need for crisis stabilization services, the Hope House was frequently at the maximum capacity of 5 voluntary beds. In April of 2006, the Montana Mental Disabilities Board of Visitors, who was tasked by the governor to review public mental health programs, conducted its first review of the Hope House. They found the Hope House to be an excellent addition to the service array in Bozeman, and that clients spoke highly of the care they received. At that time, the Gallatin County Commission pledged over $1 million toward the building of a new facility, as described in the Gallatin Mental Health Center's strategic plan. The Board of Visitors cited concerns for establishing a comprehensive training curriculum for staff, which began in May of 2006, and the need for a new facility to meet the increasing service demand. They cited a need for staff and clients to have more access to computers and a private visitation room. They noticed a lack of support in the community for those struggling with housing. These concerns were to be addressed in the building of the new Hope House. In 2010, a new Hope House was revealed to the community. The new Hope House provided 8 voluntary beds and 2 emergency detention beds and was accompanied by the opening of permanent housing named after Senator Dorothy Eck, a champion of mental health and a pioneer for women in politics. A new outpatient building would be conveniently located nearby and would later be accompanied by more housing units for clients with the Homestead House and a grant-funded peer-operated drop-in center for peer support services. The Hope House was staffed with a skilled interdisciplinary team with a common goal of meeting the needs of the clients and the community of Bozeman. The Hope House would provide on-site therapy, medication management, and case management services, as well as important linkage to other community services.
The biggest benefits to having a multidisciplinary team are that you get so many different views and scopes of practice all collaborating to provide this amazing treatment for our clients. So I'd say that's probably the biggest benefit, is that our clients get to have this huge team approach and kind of covering from all bases to encompass all of those aspects into their treatment. Some of the struggles can be that like folks who are more medically trained and medically minded can view a client's diagnosis very differently than someone who's more therapeutic or kind of the softer science trained. And so having both of those two meet, not just for diagnosing, but also for approaches and treatments and kind of which one should we treat first. Sometimes it can feel a little bit of which one came first, the chicken or the egg, of like, well, should we treat them with medications or therapy, or how can we incorporate both at the same time? So I think that can be the struggle of having such a diverse team.
I feel really confident about my team. I believe that they are, with all different kinds of experience and education, have really come together for the best of the clients. They're compassionate, and the services that they offer on a daily basis are top of the line. There are some things that I want to do moving forward, and it's all about the move towards behavioral health integration. Want to be able to offer chemical dependency assessments here in our facility while folks are here, so that they can get that service quicker when they discharge. We're also looking at bringing in a medical provider, an actual MD, to once a week, and we're working with some other agencies in town and writing a grant for that, so that we can address some of the minor things that they come in with, as well as some folks, when they're ill and have been ill for a while, haven't seen a doctor for years. And so to reintroduce them to that being an okay thing and part of their support team is to have that MD on their team as well.
I think if you get the right mix of people in those disciplines working together, it works great. We have different disciplines here, quite a few, with the APRN, with their therapists, our me as a case manager, then, clinical supervisor, CSWs that, are generally either in school or just finished with school, nurses. We have kind of a whole wide array of different professions, and I think the way that we work, it works really well because we have the communication piece down. We're constantly talking back and forth with each other to make sure that, one person isn't saying one thing and another person is saying and doing something completely different.
Clients of the Hope House are typically only admitted for 3 to 5 days. This gives the staff a short period of time with each client to make progress toward treatment plan goals. Due to the cooperation of the interdisciplinary team and high level of organization of the staff, progress towards treatment plan goals is closely monitored, observed, and recorded. The time a client spends in the crisis home often depends on the involvement of friends and family and availability of other community supports. The crisis team can only prepare a client for a successful recovery. The rest of the journey depends on the individual and their professional and personal support systems.
The majority of areas of improvement for us have been to have more food, so everyone's always hungry, and they like to have food that's very easy to prepare. So we normally have stocked cupboards, but if it's not microwavable, a lot of our clients don't know how to prepare it. So that's a teaching point that we try to do. They have talked about wanting extra blankets because they get cold. Other clients talk about how they get too hot because the heat's not consistent, but those are kind of the 3 biggest areas for improvement which we have, which tells me that the major things, the really big important things like the services that they are getting, their connection with their therapist, their trust in their medication provider, those pieces are all being met by our clients, which means to me that we're being successful at what we do. We also have a lot of people who will discharge from our facility and then they'll refer other people to Hope House. So that always makes me feel like they have to be satisfied or feel like they've had relevant change done while at Hope House because they are recommending us to other individuals who they think might be struggling.
We've been collecting data with client consumer satisfaction surveys. When they leave, they're anonymous and they can fill them out and at their leisure or mail them back or do it right then. And overwhelmingly, it's positive. We ask things like, do you feel more in control of your life since your stay here? Do you feel, were you provided med education? Was the staff courteous and helpful? All kinds of aspects of their stay, and overwhelmingly it's positive. And it's pretty consistent, the things that they would like to see changed are things that we would like to see changed too.
I think generally clients are satisfied with the services they get at Hope House. When they're ready for discharge, right, in terms of that we're saying that they're ready to go, they are in a more stable place. Even those that we discharge homeless, I would say that they might not be happy that they have to leave because they're homeless and it's comfortable here and they feel safe, but at the same time they recognize that we've helped them as much as possible and really given them some some other directions that they might be able to go if they want to change how they're living. And I would, so not just the homeless, but other people as well. Of just being here, and I've heard people say this too, and I'm gonna paraphrase because everyone says this in a different way. But I think that people appreciate being in Hope House because they get to be who they are here. They don't have to. They don't have to hide their emotions. They don't have to hide feeling manic. They don't have to hide just feeling generally awkward and weird. I mean, they get to show up, and when there's other people here too that are also struggling with things, they also see that, hey, other people struggle with things.
I think they are satisfied. I think and I can see that they're satisfied when I go meet with them at Hope House. I try to meet with all of the students that we know of that are there before they transition out, and then I meet with them again, and I know that they feel satisfied. I can see it just in their nonverbal language, and I can see it when they're released and they come back. And I've heard them refer to the staff as cool. I've heard them say things along the lines of, I've never slept so good in my life. It was a relief to go there. And then, I've heard people say things like, I didn't really want to go, but I'm glad I did.
I feel like for the most part, clients are happy with the services they receive up here. I mean, like I said before, there's a great staff and just that really safe environment and that approachable care. There are people that are easy to talk to and easy to warm.
I think the ones that are in the crisis or in the moment or still struggling with their illness may say, they don't like it up there, they don't like the Hope House, but I think the majority of the ones we find that have got some recovery and starting to have some pretty high functioning and a good baseline say that it was a great service and that it helped them, especially in lieu of the alternative, which is possibly jail or hospital stays.
Upon discharge from Hope House, each client is given a survey to voluntarily complete and return to the staff. Analysis of the results of surveys from the Hope House in 2014 and 2015 indicate a high level of satisfaction with notable correlations between items indicating that clients both appreciate and feel respected by the staff. The highest overall correlation demonstrates that most clients feel both better about themselves and more in control of their lives after staying at Hope House. These are promising results that demonstrate how services like those at the Hope House do work to better the lives of individuals in the community. The Community Mental Health Act of 1963 was legislation passed as a part of John F. Kennedy's New Frontier and was the beginning of the establishment of community-based mental health centers in the United States. This act and subsequent legislation led to a significant amount of deinstitutionalization, which is seen by many to be a double-edged sword that can be in the best interest of some psychiatric patients, but can leave others homeless and without care. In 2013, Senator Debbie Stabenow sponsored the Excellence in Mental Health Act, which set forth criteria for federally certifying community behavioral health centers. This act, in combination with the expansion of Medicaid, would in theory build on the existing framework of community mental health centers and expand the array of services available within communities. Some of the services that must be provided to meet the new federal criteria include outpatient mental health, substance abuse services, crisis mental health services, and peer support.
Really, what we do is a prevention program, right? It's really not about responding when the person's in crisis. We have CRT for that, we have law enforcement for that. This is really about people who get identified who are struggling. So Sally lives down the street, I notice her behavior is kind of strange and she doesn't seem to be doing well. It's like, who do we call? Who goes and knocks on Sally's door to say, hey Sally, how's it going? Are you okay? That's the role we play as people in recovery, right? Is to be able to just go out and just be like, hey Sally, how's it going? We're here. I know I've had my own struggles. A big piece of what we do is share our own experience. So we help reduce stigma because it's really scary. I mean, before I had a diagnosis and I was just sick, I had no idea what was happening with me. I didn't have the vocabulary. I didn't know what this was, crisis stabilization, mental illness. I didn't know any of that. To have somebody come up and say, it's okay, I've had my own struggles, and this is what it was like for me. And you begin to just build this sort of relationship. And so I want to believe, and we've demonstrated through this program, that we can reduce the cost, the high-end costs. So things like people going to the state hospital. It's extremely expensive and it's extremely traumatizing to people. What if we had a way to reach out to people before that ever happens?
When I first went into my own personal recovery, I didn't know about programs like this. I went it alone, and it was hard and it was awful. And I feel like had I have had the support that is provided at the drop-in center every day, it probably would have been a much easier road for me. And it doesn't even necessarily have to be groups. It doesn't have to feel like counseling. Just walking in and having somebody say, hey Nina, how are you today? That sense of belonging, that sense of knowing like I'm gonna survive this because people care about me. People care that I'm here. There's so much value to that, and I really wish that I would have had it then. So I think that it's something that everybody should have now.
It's critical to the whole modeling picture. It's part of the community-based care. It's part of preventive care for the mentally ill in the state of Montana. It's part of the discussion that I have as far as investments into mental health in the state of Montana. I get the picture as a whole. I understand that the more help that we can give at the lowest of levels is where we prevent these people from moving to a higher level of crisis. And on a continuum of care, that's where the dollars should be spent, because once again, peer support, crisis centers, that's the most effective way to help these people, is to keep them in their home, keep them in their community, get them back to work, and not disrupt their life. It's the modeling that has to happen.
My experience in crisis, I think that people often, when they're in crisis, are in a place of being out of control in their own lives. And so I think if we can provide a place for them where they feel safe, where we can help them regain that control, where they don't feel judged, and where they're able to, have that safety, I think that that's most important. Again, when you're having to say, I'm no longer able to be in control of myself and keep myself safe, and I have to go somewhere, that's a really difficult decision to make, and takes a lot of courage for somebody to be able to do that. And so with that, it's just that safety, that unconditional acceptance, and then helping them regain that power over their life.
Peer support for me was really the breakthrough that I needed in my own personal recovery process. So it was when I was hospitalized at a psychiatric hospital, my second time, that I got introduced to peer support. There was a guy who, this is sort of a funny story. I was there, I had tried to kill myself. It was my second suicide attempt. It was rather serious. So I was there, and this guy started following me around every day. And I really didn't know what that was. I actually thought he was a professional, and I actually thought he was there because I was on suicide watch. So this went on for like a week, and he's following me around. And he's not talking to me though, because I'm not talking, right? I'm shut down emotionally, I'm closed off, but everywhere I go, this guy comes with me. And so this goes on for like a week. And finally, one day we were sitting, we were having dinner. So there's you have your own special cafeteria kind of thing going on. So we're sitting there, we're eating, he's sitting across from me. And I just blurted out to him, I said, dude, what's your deal? Like, you don't talk, And he said to me these really powerful words. He said, I used to be just like you. And no one had ever said that to me, right? Doctors, psychiatrists, right? It's all like, here's what's wrong with you, and we're going to try to fix you, and this, right? No one ever really said that to me. I thought my experience was so unique. There was nobody like me. And of course, my next question was, well, what exactly does that mean? And it just began this conversation, and he began sharing with me his own hospitalization, his own suicide attempts. And that opened up something in me to the possibility that I didn't have to be like this the rest of my life.
Peer support programs are going to be really a core feature of community-based mental health services. And Western Montana Mental Health years ago, it's been a decade ago, really developed, hired, and trained with the knowledge that we had then, many peers within our system. And today, Western Montana Mental Health as a whole hires about 56 peers throughout our organization. So it's something that we feel very committed towards, and I personally feel a lot of dedication to make sure that that peers are always part of every service that we offer, every program that we offer, whether it's case management to crisis services.
Since 2013, there have been at least 159 school shootings in the United States. The media has provided many different probable theories as to why this number is rising, including the availability of firearms, increasing social pressures and feelings of rejection, and notably a lack of adequate mental health services. A recent study from the School of Mental Health points out that these attacks are rarely sudden impulsive acts, and that child psychiatrists and other mental health professionals play a key role in reducing risks by moving beyond a traditional threat assessment approach to one that instead assesses safety. Whatever the cause may be, the results are always catastrophic and represent a community-wide and nationwide problem. Services like the Hope House and the comprehensive school and community treatment team through the Gallatin Mental Health Center can help provide the assessment and care needed to the community to help prevent these tragedies and heal the communities when tragedy does occur.
The perception is out there that people who suffer from psychosis are violent, and the reality is those folks are more likely to be victims of violence than perpetrators of violence. We do have people who become violent, and it's such a minor percentage of the folks that come through our doors, and it's always because their perception is altered, because they're afraid. They're not the people who are out there committing violent crimes. They're the folks here who are confused and scared and trapped, and it's, usually it's all self-defense. They, don't touch me that way, whatever. And it's, they're just not the folks who are out there committing those crimes. They're not. The people who are people who are in jail and need to be.
Fear or not, mental health is getting a lot of attention with all of these school shootings, etc. So I think it's kind of putting more of an eye on the mental health care system, although typically most of these crimes aren't committed by the type of clients that we really see in true mental health necessarily, but I think it's getting more attention with that, so hopefully more funding. Again, the Affordable Care Act I know is putting a lot of funding towards mental health as well, and I'm hoping that the improvements that we're making in communication with digital systems and everything being on a computer, that kind of thing, will hopefully work in our favor for crisis systems.
There's certainly the dangerous aspects of, when with suicidal individuals, the lethality of it for everybody involved, because there's often weapons involved, especially in Montana. And so I could see, some of that perception that it's a more violent issue with mental illness, but like you said, the statistics show they're more likely to be victims of violent crime versus, the individuals provoking violence. And I think a lot of misunderstanding comes from the lack of education on the law enforcement side. So with CIT, we inform them of the needs of mental illness and stress things like distance, maintaining distance, allowing some space around the individual with mental illness, taking your time, using your words, because their communication skills are diminished, especially when they're in full-blown crisis. And with law enforcement understanding those things, it's keeping the situation safe.
I think that the words mental illness and mental health really limit what it is, because really this is adaptive behavior of human beings. This is being human. One of the things that I heard this last shooting in Oregon, he said was, it was the only way he thought he would be heard and seen. And it's like, oh my gosh, that's what most people are trying to do. They're trying to get their needs met in some way. And so when we don't get that, either we isolate, we act outward, and attack others, even if it's just a verbal attack or pushing them away, or we freeze, right? And I would say we do all of them on a daily basis. And for a lot of us, it's just these little movements, right? It's we can hide it, we can cover it up quite well, right? But for those that are really hurting, or maybe have whatever, just adaptive patterns that they've really been stuck in acting out in some way, or holding it in way too long, right? That's what it looks like.
Crisis intervention team training was designed to train first responders, law enforcement, detention staff, and dispatchers how to engage and assist individuals with behavioral or co-occurring substance abuse disorders. The CIT curriculum is a comprehensive 40-hour evidence-based training that utilizes the experience and materials of trained medical and mental health professionals to create and sustain more effective interactions with people in crisis and their families. The first crisis intervention team was introduced in Memphis, Tennessee in 1988 and was developed by Dr. Randolph DuPont and Major Sam Cochran. Research into the Memphis CIT program shows that for Memphis CIT trained officers, 100% report feeling prepared for situations involving people with mental illness, compared to just 65.4% for non-CIT officers. In Gallatin County, the CIT program has been an asset to law enforcement, the Hope House, and the community.
We have a very proactive community when it comes to mental illness, and we're all doing it for the right reason, and there's a lot of reasons to drag your feet: money, time, resources, all of that sort of thing. But what I've run into in this community is everybody's why not, and so it's the right thing to do, why not? And because we're working together, we've been able to identify holes that we didn't before because we weren't working together, and so we're starting to create more new resources every day, and we're getting better and better at trying to help people that suffer with mental illness. And from just the very basic de-escalation techniques to dealing with any crisis, any individual crisis, not just mental illness, to some specific techniques for dealing with people that have schizophrenia or borderline personality. And what we do is we do role-playing, hands-on applications, so the officers are actually using the skills and not just reading about them or watching a PowerPoint presentation. They actually go through the role-playing. And then on Friday, the end of the class, we conclude it by having some very real lifelike scenarios, and we put the officers in those scenarios using the skills they've learned throughout the week to de-escalate a very real scenario. So giving them some very concrete, realistic training that they can see that the skills work.
So we partner jointly with law enforcement and mental health to put on this annual academy within Gallatin County on educating about crisis intervention training. So we provide that training to law enforcement officers, emergency personnel, first responders. So we get ambulance staff, firefighters, we've gotten hospital staff and hospital security, all certified and trained within CIT, which is incredible. For Gallatin County, we've really become the leader for CIT in the last 3 years or so, which has been amazing for us across the state. We've started this mentorship program where we go to other communities and educate the individuals there. We meet with the stakeholders in the sheriff's department, the Bozeman, or the police department, hospital staff, everyone within those communities, and talk about what we have done to create our partnership and how we continue to maintain that throughout the entire year.
and I see the difference. You see an officer who's been trained versus an officer who hasn't, and they approach the same or similar situations very differently. And where one is much more of a policing type of role, and the other is much more of it's not necessarily a clinical or therapeutic role, but it has kind of that hat or take on it when they're assessing the situation. We had a student go to Hope House who the police officer worked with him, and instead of just putting him in cuffs and taking him, he worked for a long period of time to convince the student to go on his own, under his own duress. And some officers would say, you know what, you pose a risk. You're either going in cuffs or you're going on your own. You make the choice, and they wouldn't enter them into the conversation. But the officer who was trained took the time and made the effort to help the student calm down and help them realize that it was in their best interest to at least go be evaluated. And that's really what happened, and it was successful. And that minimized the trauma to the student and to the students in the residence halls. They didn't have to witness their peer being drug out in handcuffs.
I would strongly encourage people to adopt crisis intervention training for their communities. I think that many of our larger communities are really moving in that direction through the leadership of not only Gallatin County, but also because the Mental Health Trust had allowed money to develop the Crisis Intervention Training Board and actually sit on that board. So I have my own passion around making sure that the law enforcement officers are trained in an adequate fashion to serve those that suffer from a mental illness. I strongly believe that law enforcement, as well as first responders, whether it's ambulance, tech type staff, school personnel, should all be trained at some level of crisis intervention training. I wholeheartely believe that if we can impact people when they begin their crisis, when they're on the streets, we're going to probably service them better. We're probably going to keep them in our communities where they belong versus sending them outside of our communities. We know that people get healthy when they're around either their treatment team, their families, their friends, people they know, relationships that they have developed, or what's going to move the needle towards people moving to recovery and getting better.
By developing CIT, you are doing that community policing piece. You're proactively out there in your community, working with your community to resource this problem, and spending time and money investing in creating a CIT program, while up front might be kind of costly and time consuming, in the long run it's going to save you time because we're attacking the problem ahead of it, not waiting for it to blow up, and it's doing what's best for the community, the individuals that suffer with mental illness. But the long-term benefits for an agency, for a law enforcement agency, is they're going to be so much more efficient at dealing with this issue that they're going to save time and money in the long run.
For many on a path to recovery, the journey begins at the Hope House. The Hope House, and all the services offered within, are representative of statewide and nationwide efforts to meet the mental health service needs of a growing population. On the state level, the state of Montana has been addressing important mental health issues with legislation such as House Bills 33, 34, and 35, which provide funding for crisis intervention, jail diversion, and short-term inpatient treatment. Nationally, organizations like Mental Health America and the National Alliance on Mental Illness are advocating for people with mental health issues. Congress has recently passed the Excellence in Mental Health Act, which is projected to infuse more than $1 billion into the behavioral health system. The Hope House is respectful and representative of all of the services provided by the Western Montana Mental Health Center in that clients see a dedicated, friendly, and professional staff, pleasant and modern, fully accessible facilities, and innovative programs and treatment approaches. They maintain HIPAA compliance and confidential treatment relationships, and there is a sliding fee scale for payment, so no one will ever be denied access to service due to inability to pay. The Hope House also recognizes co-occurring disorders and values the input and support of family and other support systems. Mental health care in America is not a community problem. It is a community responsibility. Major issues in the delivery of mental health and social services still exist, and because of the fragmented system of service delivery, many services exist in silos, and communication between providers remains challenging. Payment reform is needed to address these and other pressing issues in service delivery. By streamlining behavioral health services and partnering between communities, we can overcome these barriers and deliver care that considers all of a person's individual needs, so that when a person in crisis extends their hand, service providers can meet individuals where they are and help to lead them to where they are going.
So in the last legislative session, I was the person that carried House Bill 33, 34, and 35, which are all crisis management bills. Those bills came out of the 2013 interim from a bipartisan committee, interim committee, that worked on those bills. I was the fortunate one that got to carry them. And those bills, as you know, are all about crisis prevention and jail diversion, every single one of those bills. And again, I want to mention bipartisan support for those bills. Those passed the House floor. Each one of those bills passed 100 to nothing because of the drive and the attention that we brought to mental health and that kind of a program that I'm specifically pushing for, as well as the interim committee that I came from. And so you talk about community-based care, and part of my discussion will always be community-based care versus institution. It will always be preventive versus institutionalization. And we've got to move more towards, the model in the state of Montana has got to move toward community-based. It has to move toward the preventive care.
The trio House bills, House Bill 33, 34, and 35 are real important to Western Montana mental health and imperative to those we serve in crisis situations. House Bill 33 is what we also call the county matching dollars, and that really encourages private, nonprofit, private community partnerships to look at how do we serve those in crisis in our community, and they've been, I think, really important for a couple of reasons. One of them is it encourages all of the community stakeholders to work together to assess and unify kind of in regards to, how do we serve people that suffer from mental illness, how do we serve those who are in crisis, and what does that mean to our community? And each community gets to decide for themselves, for their own set of constituents, their own set of uniqueness as it relates to all the different, community stakeholders, how to utilize that money.
We've definitely capitalized on House Bill 35. We've been recipients of that for a while, and it's helped us drive our whole crisis system. The peer support, they had a gap in their state funding, and we used House Bill 35 to fill that gap to keep them up and running while we waited for state funding to come through. We've used it to do ongoing CIT education. We've used House Bill money for research to try and go visit other communities, bigger communities that have had stuff going on for a while, and see how they're addressing things, and then bring it home here. And so without House Bill 35, we certainly wouldn't have the funding to do any of that stuff. So it's been kind of critical to our development.
Behavioral health services have become more innovative and advanced than ever before. By embracing the model of community-based mental health centers and keeping people in the community, the Gallatin Mental Health Center and the Hope House are meeting the challenges of the present and partnering with other healthcare providers to provide a more unified delivery of services that consider all of a person's individual needs. The challenges of payment reform and the barriers created by stigma will be likely targets for some time to come. New evidence-based approaches and technologies can help us here in Montana to stay connected to even our most remote communities and bring assistance to those in need.
Going over a monitor for people that are remote areas, I think for sure that's a great thing to have a conversation with someone to really explore some things. There's still the boundary of having that, like, being with another physical body. I think that's a huge component of the healing. But when someone doesn't have access to that on a daily basis, then I think that using these other things would be really important and helpful.
Well, here we use telepsych. We utilize telepsych with a psychiatrist that works for Western 3 mornings a week. He sees our clients here, so we do see that working. I'm not sure how I feel about it longer term for folks. I don't know that we're going to really have the luxury of choosing, because the need for prescribers is so high.
We've used it even down at outpatient with telepsych. I think that it's good to have, especially if you have people that you want working for the organization but they don't necessarily live here. And then they build up a rapport with a certain amount of clientele, so they keep it going by Skype or telepsych or iPhones or iPads or whatever, however you need to do it, because it's still face-to-face interaction, even though it's through a screen. You still get, especially with the way that they are now, it's like you feel like you can reach out and touch the person that you're talking to anyway.
Montana does struggle. We can't hire enough psychiatrists. We literally can't hire psychiatrists, which is the upper level of care for the mental health in the state of Montana. It's not that the resources aren't there, the people just absolutely aren't there.
Although we don't necessarily provide true inpatient services, I think we provide a unique niche that's above a regular outpatient, not quite full-on inpatient, but just somewhere in between, that I think is really helpful. I think we could, to sort of help with our services here at Hope House, I think it'd be really good if we had a good understanding of what nearby facilities may offer, what's available out there, and when to refer appropriately.
I think just being more known. I mean, that's the case for every counseling center, my office with safety and welfare. The more people know about the service, and the more people know and have a face and a name and know what the place looks like. If I could have every student take a tour by my office and I could wave and say, "Hi, I'm Aaron Gersonic," I would do that. And I think that's probably the same challenge that Hope House has, is getting to be known in that greater community. I find that Hope House is a great partner with us at MSU.
I really do hope research continues. I hope that we see stronger collaborations. We have seen a lot of dynamic changes as it relates to research around mental health. I do hope at one point that we don't see it any different than any other physical disability.